يعطيك العافية دكتور كمال عبد الحافظ.
الله يعافيك.
الله يسعدك. طبعا الدكتور مودريتر للجلسة اللي راح يكون فيها إن شاء الله الدكتور كمال عبد الحافظ والدكتور فراس مبيضين. دكتور كمال هو خريج الجامعة الأردنية في عام 1999، اختصاصه جراحة عامة من مستشفى البشير، حاليا في مستشفى جرش الحكومي. تفضل دكتور. تفضل دكتور كمال.
الو، مسموع الصوت؟
مسموع صوتك، تفضل.
نعم. معنا حيكون تشرف فيه الدكتور فراس أحمد المبيضين. دكتور فراس جنرال اند كولوريكتال سيرجري، جريت وسترن هوسبيتال، سويندون، يونايتد كينجدوم. Hepatobiliary surgeon in Royal Medical Service of Jordan King Hussein Hospital and general surgery in the Royal Medical Service of Jordan. He will speak to us about anal stenosis after hemorrhoidectomy. تفضل دكتور فراس.
السلام عليكم.
السلام.
شكرا دكتور على التعريف.
تفضل دكتور فراس.
يلا بس بدي احط السلايدز ثواني.
اوكي. شير سكرين من تحت.
شير سكرين وسكرين، مش هيك؟
سكرين بالضبط.
including now be recorded.
دبل كليك بس دكتور.
اوكي تمام. ثواني، بعرفش انا ايش بطالع عندي هلا.
دكتور شير سكرين مرة ثانية. بعدين بطلع لك سكرين، ما بعرف إذا شاشتي مبينة عندك.
مش مبينة لا.
دبل كليك.
أنا لأنه آيباد. ستارت بودكاست.
تمام دكتور. هاي بيان.
تمام.
تمام.
مبين هاي؟
تمام. تفضل.
Okay. My talk will be about a publication that we published a couple of years ago. It was about risk factors for post-hemorrhoidectomy anal stenosis. To introduce this subject, anal stenosis is a rare but a very debilitating condition that significantly limits the quality of life, as we all know. It's usually caused by factors that affects the enoderm by scarring. Common causes include excessive hemorrhoidectomy, Crohn's disease, and radiation therapy. Other surgeries that may cause it include anal fissure surgery, especially ones done without doing a left lateral internal sphincterotomy, excessive surgeries for warts, protectomy, and in addition to mucosectomy that is done with FAP surgeries, and endorectal flaps. Of course, the usual cause is scarring, and will happen excessively when we have loss of huge amounts of enoderm and mucosa. The study that we did was a retrospective study in Prince Hashim II Hospital in Aqaba. Information included was the age, sex, grade of the piles, duration of symptoms, previous history of hemorrhoid surgery, number of piles removed at surgery, setting of surgery, last follow-up visits, and whether or not the patient developed anal stenosis, of course. There were 200 patients that were included in that study. 18 developed this complication. Most of the patients, the ones who developed the complication, had 3 or more piles removed. And all the patients had open hemorrhoidectomy done, the Morgan-Milligan one. Causes for this complication include hemorrhoidectomy, which is responsible for 80 to 90% of cases. Crohn's disease surgeries are responsible for 3.3%. Other surgeries, traumas, radiation therapy, venereal disease, TB, and chronic lateral use can be reasons for the rest of the causes. Post-hemorrhoidectomy. In our study, it was 7.2% of the patients had this complication, and it usually affects 0.8 to 10% in different studies. The Whitehead hemorrhoidectomy is the one that has most risk for causing this complication, where a huge amount of mucosa and enoderm are denuded during this procedure. Also, closed hemorrhoidectomy has that risk. Open, the one that usually do Milligan-Morgan hemorrhoidectomy, and stapled rectal mucosectomy. None is superior, but stapled may be better, as mentioned in some studies. Nowadays, the hemorrhoidal artery ligation operation, transanal hemorrhoid dearterialization, laser hemorrhoid surgery, and other new models have even less complication rates, much less. Wherever there is more mucosal resection, there will be more scarring, which means more stenosis. The trend is to remove the opposing piles in the Morgan-Milligan surgery, which will make stenosis less likely. Some studies say that removal of the most bothersome pile makes the risk even less than 2%. To some, previous hemorrhoid surgery is the most important risk factor for stenosis, and removing more than 3 piles makes the risk even more. This is the Whitehead hemorrhoidectomy, where a huge amount of mucosa and enoderm are denuded, and then everything is sewed together from skin to the mucosa. This is the closed hemorrhoidectomy procedure. This is the Milligan-Morgan procedure, where we remove the piles and keep the wound open. As you can see in D, opposing piles are removed. This is the stapled hemorrhoidectomy, or the hemorrhoidopexy. And then laser hemorrhoidectomy, where we insert a probe into the pile and vaporize the veins and cause scarring inside or fibrosis inside the pile itself. And finally, this is the halo procedure, which is a very good procedure for hemorrhoids and with very good outcomes, where we do dearterization or ligation at the pedicle base, ultrasound guided or Doppler guided, and then we tuck all the hemorrhoid together to stop it from prolapsing. Tables of figures and figures from our study. As you can see, the complication happened in 7.2% of our cases using the Milligan-Morgan procedure. And most of the patients had more than 3 piles removed, and many of them had previous surgery, even another surgery for the piles. Thank you.
شكرا كثير دكتور فراس.
عفوا، شكرا.
الله يسعدك، شكرا. بنرجع للدكتور كمال عبد الحافظ. تفضل دكتور. دكتور كمال.
يلا معك، بس افتح البورد.
اوكي.
واضح هيك؟
واضح، تفضل.
صوت طالع؟
الصوت منيح.
اوكي. I will talk in brief about Mason's hemangioma case report. I am Dr. Kamal Abdel Hafiz, General Surgery in Ministry of Health, Jarash Hospital. Introduction, Mason's hemangioma is a rare benign vascular region that account for approximately 2% of all vascular tumors of the skin and subcutaneous tissue. It was described by Mason in 1923 as ulcerated hemorrhoidal vein due to its histological feature of papillary formation, anastomosing vascular channel, and the plump endothelial cells. It was earlier thought to be a variant of angiosarcoma. Due to its common presentation as a subcutaneous soft tissue lump, the diagnosis is usually not possible without histopathologic examination. A case presentation, it was a 23-year-old male patient presented to the surgical outpatient department with the complaint of swelling over the forehead region with 3 months duration. Patient complained of associated pain since a few days. Local physical examination revealed swelling over the forehead, 3.5 multiplied by 4 centimeter, the dimensions. It was mildly tender, euthermic, soft in consistency with well-defined margins and smooth surface, and was adherent to overlying skin but not fixed to underlying structures. General physical examination and systemic examination was found to be normal. Provisional diagnosis of lipoma was made. Complete blood count was found to be within normal limits. Ultrasonography was done, revealed 2.5 multiplied by 3 centimeters swelling in the subcutaneous plane in the forehead region, not adherent to any surrounding structures, suggestive of fibrolipoma. Patient was taken for excision and a mass of 2.5 multiplied by 3 centimeter. Irregular dark red mass was found in the subcutaneous plane, not adherent to any underlying muscle or bone or associated with any vessel or nerve. There was excessive bleeding from it. There was, this is the mass after we opened it. It is well-defined intraluminal pinkish red, almost solid lesion with thrombotic areas. The histopathology revealed fibrofatty tissue with numerous thick wall vascular channels on the low resolution microscopy. Many vessels showed intravascular papillary endothelial hyperplasia with thrombi formation in the vascular lamina. Some of the vessels showed fibrin thrombi in the core of the papillae. This was diagnosed as Mason's hemangioma. This is a low resolution image showing endothelial hyperplasia. This is high resolution image showing papillary projections, which is diagnostic with fibrin thrombus within it. Mason's hemangioma is considered as a reactive endothelial proliferation following traumatic vascular stasis. The lesion is almost exclusively intravascular with thickened vessel wall. Numerous papillary projections are present with organized thrombi formation within it. It is highly resembles a soft tissue tumor, especially angiosarcoma, but can be differentiated from angiosarcoma due to the lack of necrosis or fibrinous appearance and thrombus formation in the former. This was confirmed by finding reported by Kaufman and Stout that the endothelial layer of the region was composed of normal endothelial cells and that the endothelial proliferation was a benign papillary pattern and the cells showed to be atypia. Nowadays, it is considered to be reactive vascular proliferation following traumatic vascular stasis. Mason's hemangioma is a benign intravascular region rather than a neoplasm. It has been addressed by many names since the time it was first described in 1923 as Mason's tumor, Mason's hemangioma, Mason's intravascular hemangioendothelioma, intravascular papillary endothelial hyperplasia, and reactive papillary endothelial hyperplasia. It has various sites of occurrence, including the skull, thyroid, head and neck, breast, oral cavity, trunk, and extremity. It can also occur in intra-abdominal organs such as liver, although it is rare. Inter-Capillary endothelial hyperplasia is an unusual benign vascular lesion compromising approximately 2% only of the vascular tumors of the skin and subcutaneous tissue. It is usually of three types. The first type is the pure form, which occur in dilated vessels and most frequently located in the fingers, in the region between the elbow and hand, or in the head and neck. The mixed form represent a focal change in the pre-existing hemangioma, vascular malformation, or pyogenic granuloma. Undetermined form, which has an extravascular origin. Diagnosis: there is no particular diagnostic test of choice. It is usually misinterpreted clinically and radiologically as soft tissue tumor, for which ultrasonography is an ideal initial investigation, followed usually by magnetic resonance imaging, MRI. Histologically, the following are required for definitive diagnosis of Mason's hemangioma: A, endothelial proliferation within the vessel; B, multiple papillary projections; C, fibrin thrombus within it; D, no evidence of necrosis. Conclusion: Mason's hemangioma should thus be a differential in the mind of the surgeon while dealing with a soft tissue tumor due to its remarkable resemblance to the latter, although suspicion of this rare disorder would be difficult. Thank you.
شكرا كتير دكتور، يعطيك ألف عافية، وشكرا للدكتور فراس مبيضين. شكرا لكم جميعا وشكرا للحضور. وبهيك ننهي يومنا إن شاء الله، ونشوفكم على خير بكرة إن شاء الله في تمام الساعة 9 في محاضرات الأسنان. يعطيكم ألف عافية.
الله يعافيك. شكرا.
الله يسعدك.